Chapter 13, Interprofessional Collaboration for Clients with Problems of Fluid, Electrolyte, and Acid-Base Balance. The priority concept in this chapter is fluid and electrolyte balance. The exemplar in this chapter is dehydration. The interrelated concept in this chapter is perfusion. Homeostasis requires fluid and electrolyte balance. Extracellular fluid, or ECF, is fluid outside the cells. Intracellular fluid, or ICF, is what is located inside the cells. Your interstitial fluid is between the cells. That's where your third spacing occurs. That's going to be your blood, your lymph, your bone, and your connective tissue water. Transcellular is going to be your cerebral spinal fluid, synovial fluid, peritoneal, and pleural fluid. And then notice that 2/3 of your body is going to be the ICF, the intracellular fluid. For filtration, we have movement of fluid through the cell or blood vessel membrane because of differences in water pressure. So that's hydrostatic pressure. And this is related to water volume pressing up against confined walls. Hydrostatic pressure is also called water pushing pressure. And that's going to be the force that pushes water outwards from a confined space through a membrane. The amount of water in any body fluid space determines the pressure. So the more water you have in there, the greater the pressure. And they give a good example here of blood pressure. Moving whole blood from the heart to the capillaries where filtration occurs to exchange water, nutrients, and waste products between the blood and the tissue. So if hydrostatic pressure is greater on the outside of the membrane, so greater on the outside than it is on the inside, then we have disequilibrium. The body will filter from the high pressure area to the low pressure area because it wants to restore equilibrium. Edema refers to excess tissue fluid. This occurs with differences in pressure between the blood and the interstitial fluid. And you will see pitting edema in clients with heart failure. With right-sided heart failure, the blood volume in the right atrium is going to be increased due to a weakness in the right ventricle. So the right ventricle is unable to pump sufficient blood into the lungs. This is going to cause a backup in the blood in the venous and the capillary system. As the pressure increases, hydrostatic pressure inside the vessels are going to rise to a greater pressure than what's existing in the interstitial fluid. The body likes to restore equilibrium, so fluid is going to be pushed into the interstitial space, and that's going to result in edema. For diffusion, we've got free movement of particles across permeable membranes from an area of higher to lower concentration. You can see this in action if you take a raisin and you put it in water. It's going to plump up. So what you're seeing is diffusion of water. This is important in the transport of most electrolytes and other particles that diffuse through these cell membranes. Sodium pumps are going to help to move excess amounts of sodium from an area of higher concentration to an area of lower concentration. And keep in mind, where sodium goes, water will follow. And glucose uses facilitated diffusion. Insulin binds to cell receptors and causes them to be more permeable, allowing glucose to enter. Osmosis and filtration are going to act together at the capillary membrane to maintain both ECF and ICF volumes. Particle concentration in the body fluid is a major factor that determines if and how fast osmosis and filtration occur. The feeling of thirst is an example of how osmosis and filtration work together. The osmoreceptors are very sensitive to osmolality, and when the body loses water through sweating, vomiting, but not through particulates, ECF volume is decreased. The cells in the thirst center will then shrink as water moves from the cells and the hypertonic ECF, and that triggers the urge to drink. The body functions the best when the osmolality of the body fluid is close to 300. This is referred to as isotonic. Greater than 300 is going to be your hypertonic, and then less than 270 is your hypotonic. When we give a client hypotonic solutions, hypotonic IV solutions, the ICF increases and plasma volume decreases. This is because the osmotic pressure in the ICF is greater and therefore pulls water from the blood. Fluid balance is closely linked to and affected by electrolyte concentrations, but there's a lot of other factors that go into this. Age, gender, the amount of adipose tissue a client has, that all affects the amount and distribution of body fluids. Older adults, they tend to lose water. As a result, they have a lot of problems with skin elasticity. Glomerular filtration is decreased, and they have a decrease in muscle mass and adrenal glands atrophy. Obese adults also have less total water than a lean adult of the same size, and that is because fat contains a significantly lesser amount of water than muscle does. Intake of fluids, that's going to be regulated by the thirst mechanism that we already talked about, but keep in mind too, some individuals are going to have a decrease in that thirst mechanism, like the older adults. Fluid loss occurs in a variety of different ways: breathing, sweating, urinating, emesis, stool, lots of different ways to lose fluids. Hormones help to maintain fluid and electrolyte balance. Aldosterone is going to be secreted by the adrenal cortex whenever sodium levels in the ECF are low, and that's going to be for the prevention of sodium and water loss. It acts on the nephrons of the kidney, triggering them to reabsorb sodium and water from the urine. At the same time, it promotes excretion of potassium from the kidneys. When the secretion of aldosterone is blocked by medications or tumors, the potential for hyperkalemia increases due to the over reabsorption of potassium into the blood. ADH, or antidiuretic hormone, vasopressin, that's going to be secreted by the posterior pituitary, and that is in response to changes in blood osmolality. If there is an increase due to plasma osmo, especially for something like sodium, like excess sodium, that's going to cause the osmoreceptors to shrink. That triggers the ADH release, and this usually doesn't affect the electrolyte balance, just the water. Natriuretic peptides are going to be secreted by special cells that line the heart, and they're secreted in response to an increase in blood volume and pressure. So when the heart muscle is stretched, the peptides are released, and they're picked up by the nephrons, creating effects that are the opposite of aldosterone. Sodium absorption is inhibited at the same time, and then urine output is increased. And this results in a reduction of blood volume and osmo. Renin-angiotensin 2 pathway. So the blood volume and interstitial fluid are the most important to maintain balance. If you've got low volume, that's going to equal low blood pressure, and that equals death if it's not treated. So the kidneys aren't just a major regulator of water and sodium, they're also used to help maintain blood pressure and perfusion to all the organs. So when the blood pressure drops, the kidneys will sense that, and they're going to secrete renin when that occurs. So that's what we're talking about, is this renin-angiotensin 2 pathway. Renin is going to set in motion a myriad of vessel and hormone responses, and this is done to elevate the blood pressure back to a normal level. It can be triggered by any event that lowers blood volume and pressure: dehydration, blood loss, low SpO2, low sodium. And keep in mind, where sodium goes, water is going to follow. So if there's no sodium, there's no water. ACE inhibitors. ACE is going to be your angiotensin converting enzyme. This is disrupting the renin-angiotensin 2 pathway by reducing the amount of angiotensin converting enzyme that is produced. Renin does not work by itself to regulate blood pressure. It hooks up with angiotensinogen, and then ACE, the angiotensinogen converting enzymes, those come along and convert it into angiotensin. This leads to a constriction of blood vessels in the periphery, and this creates an increased afterload, and that's what the heart has to push against, and therefore raises the blood pressure. Arterioles and the nephrons are also going to be constricted, leading to lower urine output, so you're retaining more water and therefore increasing the blood pressure. So if we have a client with hypertension and we want to disrupt this process, we're going to give them an ACE inhibitor. And that's going to result in a greater excretion of water and sodium in the urine by blocking those angiotensin 2 receptors, and it's going to lower the blood pressure. So dehydration, or in the nursing world, we call it fluid volume deficit. So if you're doing a care plan, it's fluid volume deficit. But dehydration simply means that there's not enough water intake to meet the needs of the body. This is going to result in low fluid volume, especially plasma volume, and can be from too little intake or too much loss. And there's a lot of different things we talked about that can cause loss: sweating, blood loss, inadequate intake, kidney disease, big huge list on that. This can result in a loss of electrolytes, so you can have isotonic dehydration, where the ICF remains normal, but the ECF, especially, the volume decreases, so we have hypovolemia. This leads to a decrease in perfusion, and think about your vital organs and what they need. And this most often leads to low blood oxygen levels, so your patient will have a low SpO2, and these clients may need to be placed on supplemental oxygen. So when you're assessing your patient, you're assessing your client, you need to look at the signs and symptoms of dehydration. You need to take an adequate history. What led up to these events? How much food are they eating? Are they vomiting? Do they have diarrhea? What is going on with them? And then look at their overall patient assessment. Take a look at their urine output. Look at the color, if there's any sediment in the urine, if they have any weight loss. Do they have a history of kidney disease? Physical signs and symptoms or manifestations: they would have an increased heart rate, decreased respiratory rate. Their temperature might be increased. They could have what we call a weak and thready pulse, dry hot skin, poor skin turgor, dry mucous membranes. They could be altered. They could have mentation changes, so altered mental status, muscle weakness, cardiovascular signs, so they could have flat neck veins when they're upright, orthostatic hypotension. So you can actually take orthostatic vital signs on your own without waiting for the provider to order that, and you're looking for a sudden drop in pressure when standing. Lab results. So looking at labs as part of your nursing assessment. So you're going to see alterations with their CBC. It's going to be concentrated. Same thing with their CMP. You're going to have an elevated serum osmo, increased urine specific gravity in osmo. Just keep in mind with that you're going to show concentration with most dehydration. If it's blood loss, you're not going to see concentrated. You're going to see an overall drop in their H&H. Your treatment for this is going to focus on fluid replacement and correction of any imbalances. And then you need to take a look at what's causing the problems. So take a look at their meds. Are they on diuretics? Are they having diarrhea? Do they need to have some Imodium? Are they having any vomiting? Be careful with whatever's causing the problem, because that could also be a source of potential electrolyte loss, which would need to be treated. If it's orthostatic hypotension, make sure that your client is laying down. Instruct them not to get up without help. And do the same thing when you're sending them home. If they're going home and they continue to have orthostatic hypotension, some individuals live with that for a very long time. You need to educate them on how to stand up. And think about your nursing diagnosis. We already talked about one. We don't call it dehydration in the nursing world. That's a medical diagnosis. So fluid volume deficit, your patient is going to be at risk for falls. They could have a knowledge deficit. There's a lot of things that go along with this, and safety is always going to be your priority. Fluid overload. So we talked about fluid volume deficit. Now we have fluid overload, which is going to be an excess in fluid volume. So fluid volume excess. So fluid volume excess is basically put an excess amount of body fluid. So it's going to be hypervolemia, too much ECF. This can be caused by excessive intake or inadequate excretion, so like heart failure. Your assessment findings are going to include edema, so you could have peripheral edema, pulmonary edema, which is going to result in some abnormal lung sounds, so adventitious lung sounds, shortness of breath, tachypnea, tachycardia, elevated blood pressure, descended neck veins, weight gain. They could be pale. Cooled skin, altered, so they could be altered mental status, headache, visual disturbances, muscle weakness, enlarged liver, and increased motility. The other thing is, and this is the same thing with fluid volume deficit, we ignore weight changes a lot in healthcare. I'm not sure why, but we do. And weight is a very good indicator of fluid volume deficit or overload. So make sure you're weighing your patients and ask them what their baseline is. So we've gotten our physical assessment. Patient safety is always going to be our primary concern. Think about what these patients look like, what their lung sounds like, and what's going to be safe for them. This can be treated with diuretics to remove excess volume. If we do this, we need to make sure that we're keeping an eye on their electrolyte losses, especially if they're on something like furosemide, like a loop diuretic, because that's going to be potassium wasting. And there's also a lot of medications out there that spare potassium, so we need to keep an eye on it. Supplemental oxygen if they're short of breath, so we're going to monitor their SpO2, raise the head of the bed up to semi-Fowlers to help assist with breathing. Sometimes they need a low sodium diet depending on what's going on with them. So no packaged foods, cheeses, no extra salt on the tray, and then just be careful too with their potassium intake depending on what medications they're on. And these patients may also be placed on a fluid restriction, so make sure that you're telling them about it. Don't just put them on that fluid restriction and expect them to understand it. So we need to be educating them on the needs for it, educate them on performing daily weights and when they should be doing that. So we want our patient to be weighed at the same time every day, wearing the same amount of clothes on the same scale. And the other thing is when you're talking about diets with them, make sure you're asking them what their food preferences are. Getting back to the weight for just a minute, you also need to tell them when to call the doctor. So what I always tell them is 3 days or 3 pounds in one day, they need to call the doctor, or 5 pounds in a week. So electrolyte imbalances can occur in healthy people as a result of fluid I&O, so like intake and output. A lot of times we live in Florida, so that can happen very quickly with dehydration. This can be life-threatening if severe and can occur in any setting. So the next few slides, we're going to go over the different electrolytes. I want to stress to you that it's very important to have these values memorized, and you go by the values that are in your textbook. So make sure that you're making flashcards or whatever you have to do to memorize these values. So with sodium, this is a pretty major component of your ECF. It is vital for muscle contraction, cardiac conduction, nerve impulses, and I would suggest looking at the module images in Blackboard when you get an opportunity, because not only does it have your baselines listed there, but they have great information that you're going to need to know later. So we have hyponatremia first, so that is a lower than normal sodium level, so lower than 136. Low sodium inhibits ADH and BNP and triggers aldosterone secretion, and this increases kidney reabsorption of sodium. And make sure that you're reviewing the causes of hyponatremia and hyper, as well as all of the other electrolytes that we're going over, because that's going to be very important, because the cause is going to be how you treat your patient, because you want to prevent it from happening again in the future. Okay, so signs and symptoms of hyponatremia: confusion, seizures, coma, and death if untreated. I always think of it this way: the anatomical symbol for sodium starts with an N, the letter N, Na, and it causes a lot of neuro problems when it's out of whack. So that's my safety aspect of it. So I'm going to go with the number one problem, and the number one problem with sodium is going to be a neuro issue. So confusion, seizures, coma, and death if untreated. They can also have diarrhea, abdominal cramping, muscle weakness, decrease in their DTRs, rapid, weak, thready pulse. Then we have to think about the cause. If they're having hypovolemia, they're going to have low blood pressure. If they're having hypervolemia, it's going to be an elevated blood pressure. Some causes of hyponatremia could be excessive sweating. So we've got some salt loss, diuretics, low salt diet, NPO, Addison's disease, because of the decreased secretion of aldosterone. Hypernatremia. So sodium, again, we've got some causes of irritability of tissues, especially neuro, so NA, neuro, and cardiac. So please make sure that you're looking at those module images to understand both the signs and symptoms of hyper and hyponatremia. So we can have some confusion, agitation, muscle twitching. If it's late in the process, we can have a decrease in deep tendon reflexes, orthostasis, and that again depends on if you're accompanied by hypo or hypervolemia. Keep in mind too that too much aldosterone, like adrenal tumors, excessive intake, and Cushing's can also cause this. And with both of these, you really need to look at how your patient is going to be treated, what you're going to be doing to correct these issues. Think about your nursing interventions, and then think about the ones your provider is going to order, because those are two separate things. There's things you can do as a nurse without the orders, and there's things that you would need to call the provider for. So you need to anticipate what those orders will be. Okay, So potassium, normal levels are 3.5 to 5.0. And again, there's a lot of images on Blackboard, a lot of materials for each one of these electrolytes. So make sure that you're looking at that in addition to looking at your textbook and going over both hypokalemia and hyperkalemia. Okay, so causes of hypo. A lot of times it's going to be diuretics, digitalis, Cushing syndrome. Think about the effects on the adrenal glands. And then vomiting, diarrhea, and poor intake. For hyper causes, a lot of times it's going to be kidney failure is going to be the big major one because they're not excreting enough potassium, but it could also be caused by overingestion of potassium like bananas and sweet potatoes. Salt substitutes are notorious for having too much potassium in them. Adrenal insufficiency like Addison's disease and ACE inhibitors as well. Think about all of your potassium sparing diuretics out there. Treatment of hypokalemia focuses on replacement. It can be IV or PO. Just keep in mind that potassium IV is very caustic to the veins. When administered IV, it has to be diluted. If you're giving an IV, like, you know how with IVs, I know you've seen this before, so they'll have a bag, it'll say like 0.9 with 20 of K, like 20 of potassium, and it's a whole liter of bag, like a whole 1,000 cc's. So that whole bag is 20 milliequivalents of potassium. What I'm talking about are the smaller bags, so it'll be like an IV piggy bag. So those have to be put on a pump by themselves. They have to be administered slowly. They burn. If they do burn, you need to slow down the rate or apply a warm compress. If it's infiltrated, of course, you need to stop the IV. You never, ever, ever, ever give potassium IV push. Ever. If you're giving it orally, it tastes absolutely terrible. So make sure that you're diluting it with something that tastes a little better and offer some oral care afterwards. Signs and symptoms are going to be of hypo are going to be lethargy, shallow respirations, muscle weakness, orthostasis, altered mental status, and constipation. With hyper, it's the opposite. They're going to be Brady, hypotensive, and they're also going to have some EKG abnormalities. So you need to be looking at that. They could have peak T waves, prolonged PR, YQRS, VFib, asystole, pretty serious. And then paresthesia is progressing to flaccid paralysis and diarrhea. Getting back to the cardiac for a minute, your priority with hyperkalemia and also with hypo is to get an EKG on your patient. So you need to be taking a look at that. Get an EKG, get them on telemetry. So other thing with this is make sure that you're thinking about your other interventions and your treatments. And again, there's some very good charts and information on Blackboard and in your textbook. Calcium. So normal lab values for calcium are going to be 9.0 to 10.5. Okay, so PTH, when low calcium levels are detected, PTH stimulates calcium release from the bones. And this is an increased activation of vitamin D to help with interstitial absorption of calcium. And this inhibits calcium excretion in the kidneys. This stimulates the kidneys to reabsorb calcium, so when the parathyroid doesn't function properly due to things like hypoparathyroidism, the client can quickly become hypocalcemic. If the parathyroid malfunctions are prolonged and too much PTH, it's hyperparathyroidism. The client can quickly become hypercalcemic if that occurs. Thyroid calcitonin is going to be secreted by the thyroid gland, and this is going to be the opposite of PTH. It suppresses the release of calcium, inhibits vitamin T uptake, and increases excretion of the kidneys. So with hypo, hypocalcemia signs and symptoms are going to be paresthesias, numbness, tingling, cardiac changes, again, so prolonged QT, prolonged ST, also some abdominal cramping, diarrhea, and then our favorite, which you're going to see a slide on next, is going to be trousseaus and schwastics. The causes of this are going to be thyroidectomy, so that's going to cause hypocalcemia, hypoparathyroidism, renal failure, and malabsorption. With hyper, signs and symptoms are going to be bradycardia, blood clots, muscle weakness, a decrease in DTRs, constipation, anorexia, and nausea and vomiting. The causes are going to be too much intake. So I've seen it a couple times where it was actually Tums that caused the problem. The patient was eating too much Tums because of heartburn, so that can cause some issues. Too much intake, hyperparathyroidism, kidney failure, thiazide diuretics, dehydration, and mobility. So here's two assessments that occur with hypocalcemia. This one's called trousseaus, and this one is called schwastics. I'll make sure that I post a video about these two so that you can see it in action, because usually what happens is your CNA will go in to take vitals, and hopefully they come get you if this happens, but your patients, oops, let's go back. They'll have some palmar flexion. So this part of the hand will flex, and sometimes it will actually come in towards the body. So sometimes they'll have such a severe contraction it'll pull in. So that's trousseaus, and I'll post a video. This one is schwastics. So that's like a facial muscle response, and it's called schwastic sign, and it's indicative of hypocalcemia. So sometimes if you tap on these patients' face, not only will that muscle twitch, but sometimes their whole head will jerk to the side. It just depends on how sensitive the patient is. If you have a client that demonstrates this, like say the CNA comes to get you and they have trousseau sign, go ahead and do schwastics as well, and then call the physician to get an order for a calcium level. Magnesium, normals 1.8 to 2.6. Again, I know I mentioned it before, but you need to check out those modules that are loaded on Blackboard and be looking in your textbook and memorize your lab values. Okay, so magnesium critical for skeletal muscle contraction, carbohydrate metabolism, ATP, adenosine triphosphate formation, vitamin activation, and cell growth. So hypo, the main cause of hypomagnesia is going to be your loop diuretics or poor intake. So alcoholics are very prone to this. They're very prone to a lot of electrolyte imbalances and mineral imbalances because they're prioritizing their alcohol intake over their food. So generally their nutrition is going to be very poor. For hyper, well, let's get back to hypo. So hypo, they're going to have increased risk for hypertension and atherosclerosis, dysrhythmias again. So this time it's going to be PVCs, AFib, VFib, and long QT intervals. So you're going to want to make sure that you get an EKG on them as well. Neurologic changes, increased nerve impulses, hyperactive DTRs, numbness and tingling. They could also have tetany as well, because that's what schwastics and trousseaus are tetany, and reduced intestinal motility, nausea, vomiting, and constipation. For hyper, we're going to have some bradycardia, peripheral vasodilation, hypotension because of the dilation, prolonged PR intervals, wide QRS complex, and cardiac arrest if severe. They could be drowsy, lethargic, and weak muscles, and that can lead to respiratory failure. So both of these are pretty serious. A lot of times, kidney failure is a problem with these. And patients with kidney failure really should not be taking milk of magnesia and things like that because that can lead to this. As always, there's a lot of considerations for older adults because they are at the most risk for electrolyte imbalances and age-related organ changes. They have less total body water than younger adults, so they're at risk for fluid imbalances. And they're also more likely to be taking things like diuretics that are going to impact fluid and electrolyte imbalances. Okay, so that's the end again. And we have review questions, so I will make sure that these get posted on Blackboard so that you can go over them. So this is the end of Chapter 13, Interprofessional Collaboration for Clients with Problems of Fluid, Electrolyte, and Acid-Base Balance.